Hello, I am Dr. Mirela Cerneianu, and I welcome you to the Wellness Optimizing Warrior MD podcast, the WOW MD podcast. I am not your typical wellness coach, and this is not a typical wellness podcast. Here, I'll discuss educational facts about health, hormones, intimacy, anti-aging, and beauty trends, all very hot topics, to empower you to make great choices when it comes to your health and to your body. I want you to go, wow, I did not know that. Or, wow, this is going to make a great difference for me. Our healthcare system is broken and it needs a revolution. You and I can start one today. I am willing to share my knowledge with the world if you're willing to listen. Let's get started. Welcome back. I would like to continue my series on podcast episodes about pelvic female organ pathology and specifically about uterine cancer. However, today's episode is a topic that pertains to all pelvic organ pathology and all cancers, not just uterine, but it's basically a little divergence that I'm going to use, and I'm going to talk about the estrogen receptor and how important it is for our health as women, and why, if you had no clue that you have estrogen receptors, what they are, what they do, you should care now, because I'm going to tell you some amazing, wowing things that are going to blow your mind about what this receptor is doing and why it's so important for your body. Again, I'm going to continue with the theme of how to prevent uterine cancer. And this episode goes a little bit more broadly. It will discuss estrogen receptor disruptors and their correlation with uterine cancer risk, but it's all cancers that have estrogen receptors on them, including breast cancer. So whatever we're going to discuss today, it's also pertinent for other female cancers. First, let me do a quick recap and let me talk about what is our estrogen hormone, because that seems to be something that many women are still confused about. Many women think that estrogen is the enemy and estrogen is going to give them cancer and it's a bad hormone, it's going to make them gain weight. Well, it's not. After I explain estrogen very briefly, for more details, please go back to my first couple of episodes. They're very detailed about estrogen. After that, I will explain estrogen receptors, and then we will launch into estrogen receptor disruptors. And last but not least, how they correlate with cancer risk, specifically uterine cancer in our case, because we're on this subject. So estrogen is a hormone that plays a crucial role in the growth and development of the female reproductive system. You're going to find this phrase everywhere you look if you do a Google on what is the estrogen hormone. That includes our uterus. Very important for our uterus. Now, what you're not being told, and it doesn't say anywhere, but you can read the subtext, estrogen is our amazing female hormone that has hundreds of functions in our female body and influences us, women, from head to toes and from inside pretty much out our entire body. Now, our body makes estrogen after we enter puberty and we start having periods. And our body can continue making some estrogen beyond menopause, but for the majority of women, estrogen production stops at menopause. However, it is important you have some knowledge about the types of estrogen that your body can make and why they are important and why they are different. The most significant and powerful type of estrogen that our ovaries make is estradiol. There's a much weaker form of estrogen, estriol. We mainly produce this type of estrogen during pregnancy. And last but not least, our bodies can produce estrone, the dominant form of estrogen, during our natural or surgical menopause. The estrone is mainly derived from peripheral conversion of androstenedione, a hormone made by the adrenal, into our adipose tissue. So the more fat we have after menopause, the more likely we are to have estrone in our bodies. Why does that matter? It matters because estrone has been deemed weaker than estradiol and with potential to increase risk of cancer. Abnormally high estrone levels will lead to fibroids, heavy periods while we're menstruating, PMS, other mood changes, fibroid cystic breasts, possibly cancer. So again, this was just a brief summary about the three types of estrogen. So now let's talk about the estrogen receptor. the highlight and the main topic of this podcast episode. Estrogen works in our bodies, has an effect only by binding to a specific protein that is called the estrogen receptor. This estrogen receptor is present inside the cells of various tissues, including the uterus. Now, estrogen receptors are located absolutely all over the body. As I mentioned, estrogen has hundreds of functions in our female bodies, and there are receptors from head to toe and inside and out, meaning you will have estrogen receptors in your brain, in your neurological system, in your heart, in your blood vessels, in your musculoskeletal system, and obviously in your female pelvic organs and your breast. For now, let's talk about these estrogen receptors. Just a quick informational tidbit. They exist in two forms: estrogen receptor alpha and estrogen receptor beta. In the breast tissue, estrogen receptor alpha activation will cause cellular growth, whereas estrogen receptor beta activation will cause regression of cellular growth. So that's very interesting, and I'll come back to this. The binding affinity, so their ability to bind these two types of receptors to estrogen, is very different for the various types of estrogen. For example, estradiol has an equal affinity for binding both alpha and beta, but estriol has a higher affinity for the beta receptors, which again inhibit cellular growth. That is why estriol can be used safely even by estrogen receptor positive breast cancer patients, while estrone will mainly bind the alpha receptors, which means it will always cause significant cellular growth and development. And again, unbalanced cellular growth leads to cancer and bad things. So estradiol has an equal binding affinity for alpha and beta, so you can see the balance there. This is our main estrogen hormone. Estriol mainly binds to the beta receptors and estrone to the alpha receptors. So estrogen receptor alpha is mainly present in the breast, the uterus, the ovarian thecal cells responsive to the LH hormone. It's also present in the bone, in the male reproductive organs, the testes and the epididymis, the prostate stroma, the liver, and our fat cells. Estrogen receptor beta, by contrast, are present mainly in the prostate epithelium, into our bladder, our ovarian granulosa cells that respond to the FSH hormone, in the colon, our immune system, and also our fat cells. Now, both subtypes, alpha and beta receptors, are markedly and significantly expressed in our cardiovascular and central nervous system. There are some very common physiological roles for these two receptors, like the development and function of the ovaries and the protection of the cardiovascular system. What you need to remember is that the alpha subtype has a more prominent role on the breast and the uterus, as well as on the preservation of our skeletal homeostasis, so the strength of our bones, and the regulation of our metabolism. The beta subtype seems to have a more profound effect on the central nervous system and the immune systems, and generally, it counteracts the alpha-promoted cellular hypergrowth and proliferations in tissues like breast and uterus. So remember, alpha activation, growth, proliferation, and beta balance and safety. These specific estrogen receptors mediate the actions of our estrogen in our target cells, all their target cells, and they are involved in regulating cellular growth, proliferation, and differentiation of various cells in different tissues. In the context of uterine cancer, because we've been on this topic for the past couple of episodes, any abnormalities in the estrogen receptor signaling can and will contribute to the development and progression of uterine cancer. And it makes sense that if we have estrogen receptors in our breast and uterine tissue, then the majority of cancers that occur in these tissues will be estrogen receptor positive and progesterone receptor positive. Estrogen receptor negative uterine and breast cancers do not express estrogen receptors. They will not be influenced by estrogen stimulation. These tumors have a very different biological behavior and may require different treatment approaches like chemo, radiation, or targeted therapies that do not rely on hormonal manipulation as the estrogen receptor positive cancers are. So again, the estrogen receptor positive uterine and breast cancers are characterized by the presence of estrogen receptors on the cancer cells. In these cases, estrogen can stimulate the growth of cancer cells by binding to the estrogen receptors and activating signaling pathways that promote cellular proliferation. Now remember, estrogen, it's a very good hormone. It's our God-given hormone that we've had for decades in our bodies. We are born with this hormone. We are programmed with this hormone. The only way it would actually do the bad thing, activate the signaling pathways that promote abnormal cellular proliferation, would be when the estrogen will be acting on its own for a long time, unchecked and unbalanced by its sidekick, progesterone. Or, and pay attention to this, or your estrogen receptors are hijacked by estrogen receptor disruptors. And now the normal signaling pathways go out the window as the estrogen receptor activation by these disruptors pretty much acts like a virus that takes over the cells. So who knows what's going to happen? Now, I'm going to repeat this. What if it's not our estrogen that's supposedly going nuts and overstimulates estrogen receptors? What if instead estrogen is not to blame at all? It's a wonderful, beautiful hormone. What if our estrogen receptors are hijacked by estrogen receptor disruptors by chemicals? And now our normal signaling pathways, again, simply go out the window, and the estrogen receptor activation by these foreign chemical molecules acts like a virus that takes over our cell, and its normal processes are completely disrupted, creating the stage for unchecked, uncontrolled proliferation and division. In other words, creating the stage for cancer. We're going to say, well, wow, I've never heard of this before. We've known that this is the case. And I'll talk more about this in my next episode, but we've known since 1990s that we are overburdened by endocrine receptor disruptors, and it's been a big problem, and that they cause cancer. Coming back to my topic, what are these estrogen receptor disruptors? Well, in order for you to understand what a disruptor is, let me talk more about the mechanism of how estrogen interacts with its receptor. All the sex hormones, and this is something you should know, estrogen included, normally pass through the plasma membrane of a target cell, any cell in our body, and adhere or stick themselves to an intracellular sex hormone receptor that's present in the cytoplasm, which is the body of the cell, or in the nucleus. Now, the cell signaling pathways are triggered and induced by the sex hormone, and this will regulate specific genes on the cellular DNA in our nucleus, generating different kinds of actions. Now, estrogen receptors can bind to various molecules, and they can have an agonistic effect, which is similar to what estrogen would do, a mixed agonist-antagonistic effect, or a full antagonistic properties, which is exactly the opposite what estrogen would do. Again, I'm going to repeat this. Estrogen receptors will bind to various chemical molecules, not just estrogen, that can have agonist, mixed agonist-antagonist, or full antagonist properties. The mixed agonist-antagonist chemicals are also called SERMs, or selective estrogen receptor modulators, and they display distinct pharmacological effects depending on the target tissue. One of the most common ones that some of you might have heard of is tamoxifen, has been widely used for clinical treatment of breast cancer as an antagonist. However, it acts as an agonist in most estrogen target tissues outside of the breast. Coming back to the estrogen receptor, the role of our estrogen receptors far transcends the most commonly described purpose of regulating development of female characteristics and the female reproductive system. Estrogen receptors are indispensable in a diversity of physiological processes that include regulation of lipid profile, bone integrity, homeostasis of the body's processes, immune system, endothelial functions, inflammatory markers, the growth of different tissues, and development before and after birth. Now, because our estrogen receptors are found in so many tissues, and because estrogen is such a crucial hormone for the female body, impacting all of our organs and systems, again, head to toe and inside and out, our receptors for estrogen have to be extremely versatile. They have to be extremely flexible because estrogen receptor characteristics for affinity and downstream effects after activation cannot be the same in the breast and the uterus as they are in the brain, in the bone, in your cardiovascular system, in our skin, in our eyes, etc. Continuing the discussion about our estrogen receptor, and I'll come back to this thing, the flexibility and the versatility of our estrogen receptors. That's a quality, but it's also a big problem. This is just setting the stage for what I'm going to say next. The biological process where a hormone interacts with its receptor takes place in our body and involves a very specific, highly specific process. This high specificity between the receptor and the hormone is pivotal in allowing our bodies to switch on and off only the correct and appropriate receptors in order to produce the correct and appropriate response that we expect from this interaction of hormone to receptor. This concept, this high specificity concept, is what gave birth to the conventional lock and key model that is widely accepted, which is the modus operandi of many hormones in our body. Let's talk more about this lock and key mechanism. You might have heard me mention this before in one of my Instagram posts. Estrogen receptors work just like any other steroid hormone receptor. Cortisol, androgen, progesterone, they work in the form of a key and lock mechanism, where your hormone is the key and the receptor is the lock for that specific key. So each one of your hormones, the sex steroid hormones, is a key, and there's a specific receptor for that key. Imagine your body as a very large condo building with a multitude of individual condos on multiple floors. Each one of these condos has a totally different key that allows entrance into that condo only. The way steroid hormones work is by actually entering the cell through passive diffusion. They just sink right in. Then, once they sunk into the cell cytoplasm, they combine with the receptor. And then they target the nucleus of the cell, where it will program specific actions depending on the cell that it is interacting with. This concept and this specific type of interaction, it's very important for you to understand. Because if the receptor is broken and malfunctioning, then the key will not be able to activate the lock, meaning your hormone might not be able to do its job because your receptor is broken. Your body might actually sense there is a problem, send signals to make more of the key, so your body might instead keep making more and more of the same hormone. Though this hormone cannot interact with the receptor, your body might not understand that the problem is the receptor, so will keep making more keys to try and open the lock. That is what happens with the insulin receptors, and we're not sure if this might actually happen with other receptors, including the estrogen receptor. This brings me to a very important point. The health of our estrogen receptor is absolutely crucial for a normal functioning of our estrogen hormones. So estrogen is not the problem. Our receptors might be. Now, let's talk about what if it's not the receptor that is broken? What if this receptor is simply occupied by a foreign key, a disruptor? Food for thought. I'm going to come back to this in a minute. So remember how I started talking about the estrogen receptors and mentioned the key and lock mechanism, which requires a very high specificity for the hormone receptor interaction? There's only one key for that specific receptor, and that key only works with that lock. Well, as it turns out, this mechanism of high specificity, one hormone one receptor. As it turns out, the estrogen receptors specifically are an exception to many of the core actions of this specificity concept. The key and lock mechanism doesn't always apply to estrogen receptors. Why? Because it turns out that the estrogen receptors, quite unlike the other members of the steroid receptor family, who have very specific actions on very limited tissues, estrogen receptors are also able to bind to a remarkably diverse range of exogenous substances, foreign substances, which has earned them a notorious reputation, I'm talking about the estrogen receptors, as being very promiscuous. Now, who heard this term, promiscuous receptors? But it's very, very interesting. It's an actual phrase from an article entitled Versatility or Promiscuity, focused on discussing the estrogen receptors. So I thought that's pretty cool. So I decided to mention it in the podcast episode. Now, I want to let you know, just in case you don't know, this has nothing to do with sex. The definition of promiscuity is actually characterized by or involving indiscriminate mingling or association. So these receptors are not discriminate. They're not very selective, and they can bind pretty much to anything that is remotely similar to what they would normally bind to. And this is the key. Why we have so many problems with all these chemicals and why we're so sensitive to those chemicals. Molecules that are able to bind to the estrogen receptors span from industrial byproducts like polychlorinated biphenyls, dioxins, to plasticizers like phthalates, plastics, bisphenol A, BPA, naturally occurring phytoestrogens like genistein, which occurs in soy, or pharmaceutical products like diethylstilbestrol, DES, all the way to pesticides like DDT. All of these chemicals can bind to our estrogen receptor. That is absolutely fascinating. You should be wowed. This is incredible. And it is incredible because despite the structural diversity of all of these different chemical molecules, they're all different chemically. They all appear to possess at least an aromatic ring structure, which is believed to be crucial for having the affinity to bind to the estrogen receptor. So, frequently referred to as endocrine disruptors, these compounds, a very large number, have been implicated in numerous and diverse adverse side effects. Some examples of the adverse health outcomes of these disruptors are infertility, precocious puberty, various cancers, breast cancer, cervical cancer, vaginal cancer, testicular cancer, uterine cancer, obesity, diabetes, cardiovascular, and immune problems. There's a ton of research done in this area specifically because many of the female cancers like uterine cancer and breast cancer are characterized by the presence of estrogen receptors. So hormone therapy targeting estrogen receptors, like these selective estrogen receptor modulators I mentioned earlier, the SERMs, or aromatase inhibitors, may be used in the treatment of estrogen receptor positive uterine cancer. Again, patients with estrogen receptor positive uterine cancer might benefit from hormonal therapies because these hormonal therapies target estrogen receptors to block the proliferative effects once the receptor is activated. The problem is that these medications target the proliferative effect of estrogen. They're anti-estrogens. SERMs, selective estrogen receptor modulators like tamoxifen and aromatase inhibitors like Arimidex, are commonly used in the treatment of these estrogen receptor positive uterine cancers and breast cancers to interfere with our estrogen signaling and inhibit cancer growth. So again, this type of treatment is very interesting because a woman at menopause has no estrogen, normally, naturally, unless they're on estrogen hormone replacement therapy, but the majority of women who develop breast cancer are not on hormones. The development of cancer is likely the consequence of years of unchecked and unbalanced estrogen and probably exposure to decades of estrogen receptor disruptors. So choosing these drastic measures that focus on negating estrogen effects instead of choosing high-dose progesterone or testosterone, they're both natural estrogen receptor antagonists, does not make sense to me. Most of these drugs, the aromatase inhibitors and SERMs, the estrogen receptor modulators, have some very drastic and debilitating side effects. Now, again, this is a personal opinion. I'm not involved in any type of cancer research or treatments. I'm just trying to use some logic and present some facts and open your mind to ask more questions of your doctor that might be involved in the cancer treatment. So again, maybe it's not even the high estrogen at all. What if the cancer, it's actually caused by this broken receptor problem, by this receptor that's persistently activated by the wrong key, by these chemicals, the disruptors. This allows estrogen receptor disruptors to activate the cell, cause proliferation and growth when they shouldn't. So I'm going to end here. Please stay tuned. Next week, I will talk about the top 10 signs and symptoms of possible exposure to estrogen receptor disruptors and top 10 ways to detoxify our body of these disruptors, as well as the top 10 key characteristics of how these estrogen receptor disruptors interfere with our hormones. Thank you for listening. If you liked the information you heard and you'd like to hear more, please subscribe and follow my podcast. Should you find the content helpful to not just you, but possibly others, please share it and feel free to leave us a review. You are welcome to join the Facebook group, The Warrior Optimizing Wellness MD. I certainly hope that you've heard many things in this podcast that made you go, wow, I did not know that, or wow, I'd like to know more. So keep listening and I'll keep talking.